So hello everybody. I just want to say first of all, before I get started, that I want to acknowledge that for those of you in the room who have lived experience or have living experience of severe and multiple disadvantage, be that problem substance use or homelessness or any of the other aspects, I am going to talk about some difficult things later on, and I just want to acknowledge that, but it's also really important to talk about what we know and about the evidence base. So just to give you some context about my background. So I work most of my week at the University of Glasgow, where I teach and do research. But I also am a founding member of GPs at the Deep End, a project that seeks to try and improve care both for patients and for practices experiencing high socioeconomic deprivation in Scotland. I work half a day a week in homeless health services as a GP in the homeless GP practice, and I also work half a day a week as a medical officer in South Area Rest at the Gorbals, and I'm delighted to see some of my clinical colleagues here today. So what I'm going to cover in this 15 minutes, and I really hope to leave 5 minutes for questions, is I'm going to talk about some definitions and some theoretical perspectives. I'm then going to cover physical health needs, and then I'm going to talk through a wee bit about the recently published NICE guideline, and then 5 minutes for questions. So first of all, I was introduced as a professor of general practice and inclusion health. And I just want to sort of define what inclusion health means, because it's really relevant when we're trying to pin down what complex needs might mean. In Public Health England, define it as people who are socially excluded, typically experience multiple overlapping risk factors for poor health, experience stigma and discrimination, and are not consistently accounted for in electronic records. And this generates barriers in access to care and extremely poor health outcomes. And that really is the sort of perspective that I come at this from. But you will also maybe have noticed the introduction to my slides. We were given the brief that this was about meeting the physical needs of people with complex needs, but I want to reframe that. I don't think that complex needs is a useful term, and I'm going to explain why I think that. I was the primary care rep on the NICE guidelines that were published in March 2022. And I'm not sure how many of you in this room have been on a NICE guideline committee before. It's a very rigorous process. There's a lot of time spent looking at the evidence base. And we pull the draft guideline together, and then it goes out to lots of stakeholder consultation. As you can probably imagine, so this was a guideline that was about meeting the health and social care needs of people experiencing homelessness. And as you can imagine, we agonised at times over what words to use, what the right words were. And we initially had complex needs in the draft guideline, although there'd been lots of debate. But when it went out round all of our stakeholder consultation with lots of organisations with lived experience, they came back and said, no, complex needs A is meaningless and B is really discriminatory. We want this changed, and what we suggest you use instead is severe and multiple disadvantage. Now, many of you in this room will be familiar with the Hard Edges and the Hard Edges Scotland report, and really, the definition that NICE decided to go with is very much draws on the Hard Edges experience, and I'll leave you to read that for yourself. When I then go on to talk about the evidence later on, it is some of the evidence is exclusively about people experiencing homelessness, and some of the evidence is exclusively about people who are struggling with problem substance use, and then sometimes it's about an overlap and explicitly about SMD. I just wanted to bring this in because I'm actually now going to pull the focus out a wee bit, because I think one of the things that it's really important to remember is that as clinicians or as professionals or as people who are using services, it's important to try and keep track of the fact that we're actually part of a system within a bigger health system. And I just wanted to acknowledge that for people who have had lots of difficult adverse experiences across their life, and on an ongoing basis, that actually the work that people need to do to be able to interact with healthcare in a way that's helpful, and to manage to do the work that we often as professionals ask of them actually takes a lot of effort. And I think that picture, it's an old picture, but I think that picture sort of illustrates it best, certainly for me. And I just want to highlight as well some recent work that's been done in Glasgow that's looking at two of these overlapping disadvantages, that of experience of homelessness and experience of injecting drug use, which is Richard Lowry and colleagues actually measured treatment burden. There's a well-validated tool for measuring what we call treatment burden, the work that a patient needs to do, and actually the findings were really stark and quite shocking, in that this relatively young group of people had really, really high treatment burden. And so, again, that whole idea of us framing this in the bigger picture. We are part of the global health community. Global health, the best recognised definition of global health is that it's seeking to achieve health equity. So that's what we're trying to do. And when we're thinking about physical health, my pitch to you is that we should be thinking about it within the context of primary care and general practice. And I just want to, for some of you this will be a familiar declaration, but this is the sort of recent WHO update about the central role that primary health care has in meeting people's needs. And it's the most inclusive, effective and efficient approach to enhancing people's physical and mental health. And it is a cornerstone of a sustainable health system for universal health coverage and to try and help us reach the Sustainable Development Goals. So I want you to hold that in mind as I talk about the rest of the session. But I also just want to sort of highlight another way of thinking about this, which is very, very commonly thought about in terms of sort of global health and international health circles. It's this tension between horizontal and vertical healthcare systems. So horizontal means that you think about all of a person's health needs when you're thinking about delivering services, whereas vertical health teams tend to think in sort of discrete health, illness entities. So a good examples in the UK setting would be thinking about tackling bloodborne viruses. And then I just want to highlight what we have known for a long time now, following the work of Barbara Starfield, is that primary care is generally thought to have 4 C's. So it's about providing comprehensive care to people, it's about providing first contact access, it's about coordinating care, and also really importantly, it's about continuity of care. But then you have the lived reality of what service delivery and experience is like in the UK at the moment. And as you can see from this graph here, this is now old, it's pre-pandemic, but this has been a really influential graph in general practice because it really shows, and so basically the lines across the bottom are the actual ability that people have as GPs to deliver care, and then the graphs that totally disengage from it and go that way, or the lines that go that way, are about actually the outcomes for people and the comorbid physical and mental health conditions that people have. There's a large mismatch between what people need and what primary general practice actually provides at the moment. And unfortunately, the most recent iteration of the GP contract, there's no evidence to suggest that that's closed that gap in any shape or form. So next, and I'm just going to check my time. Okay-ish. So next I want to just cover, take a bit of a step back and look at the burden of disease in Scotland so that we can get a sense of where people's physical health needs might fit in for a severe and multiple disadvantage population. And just, so you can see that cardiovascular diseases are really important, cancer is important, mental and substance use disorders are really important. And you can have a scan yourself of all the different ones. That's 2015 this was published. How much that's shifted over that period of time is hard to know. But I think in general, this is a good sense of where we're at a population level in Scotland. So now focusing down more onto the experience of severe and multiple disadvantage and what we know about the physical health needs of people for that in that sense. So we know that multimorbidity, that's the presence of 2 or more long-term conditions, is much more common at a younger age in disadvantaged populations. And we did a very small bit of work looking at the population within our homeless GP practice. We found rates of SMD were very high, but we found that despite our patients having an average age of 43 at the time, they had levels of multimorbidity that matched an 85-year-old population in the general population. And even, that's our work, it's the sort of our day-to-day work, but it really helped us understand why we felt it required so much effort and resource to effectively meet people's needs. Aldridge et al. In the Lancet in 2018 published a big review looking at what illness, that's what morbidity means, illness is for people who were experiencing homelessness. Who were experiencing severe and multiple disadvantage. They looked across all factors, and they highlighted the role that infections have, bloodborne viruses and latent TB. They highlighted respiratory disease, cardiovascular disease. And then a different team of Aldridge et al. Looked at mortality outcomes for people experiencing homelessness. And this was people who'd been admitted to hospital with having been flagged as homeless. This is not the same as the usual ONS data that looks at mortality outcomes. And they flagged cardiovascular disease, cancer and respiratory diseases as big causes of death. But overrepresented were external causes such as accidents, self-harm, assault and events of undetermined attempt. But the really key finding from that bit of work was that 30% of deaths are amenable to timely healthcare. So there's a huge gap between people's needs and what is offered. And then another very recent paper by Dan Lure and colleagues in Lancet Public Health, when they looked at a data set, they found that although alcohol and drug-related deaths are important, basically not as much as some data sources suggest. Cumulatively, more deaths are related to what we call non-communicable diseases overall in a large cohort of people who inject drugs. So again, it's that whole complicated thing about different data sets give you different lenses and different views into what's going on. And Emily Tweed, colleague here in Glasgow, has just recently published work that looked at the overlapping experiences of SMD in the Glasgow population. And again, she really highlighted that avoidable causes of death, including non-communicable diseases, is really important. So I think that if there's a take-home message from this, it's that absolutely paying attention to alcohol and drug-related deaths is really important, but actually the wider context of other non-communicable diseases is as important, and there's a big gap there. How am I doing for time? 6 more minutes, right? Okay, so I'm going to canter through this, and I think the slides being shared with the delegate, with you guys. Yeah. So I wanted to so that can feel really paralysing when you hear that negative messaging about how we're actually not really meeting the physical health needs that well of people experiencing severe and multiple disadvantage. I just want to give you a bit of a ray of hope, which I think is NG214. I think it's a really great aspirational document that is a good route map for how we think about service development and design as we go forward. And as I've mentioned already, this is about inclusion health populations. Although it says homelessness on the tin, actually it's about all inclusion health populations, and that's acknowledged in the guideline and the role that sort of intersectionality has for people. So so just totally rattle through this. So I think the headlines for me is that it says that more effort is needed and targeted approaches are required, and that the same standard and quality of services should be available as for the general population. So this idea of second-rate services for people experiencing SMD, that should be a thing of the past. It's really important that we think about engagement, sustaining engagement, and then re-engagement when that's needed. And psychologically and trauma-informed care is an underpinning one as well. that we need to think really carefully about effective, appropriate communication, that missed appointments need to be filled up on, and that really follows on from work that I led on here in Scotland, which I don't have time to talk about, but you can ask about if you want to. There's an important role for patient advocates in all of this. And then, because in England the NICE guidelines actually got statutory status, commissioners need to pay attention to this and actually think about commissioning. So it should be multi-agency. Proportionate universalism principles need to be applied, and that you need to think about what resources needed, and it might be more for people with more unmet need, and that's about more targeted services, and that might mean smaller caseloads. Really importantly, that up-to-date local needs assessments are used to design, plan and deliver services. And there's some other stuff in there as well, which I will skip over. Now, the key thing, again, another key element of the guideline is that in specialist services, in places where there's sufficient populations for specialist services to be set up, the multidisciplinary team has a central role. That there should be a key person identified with each patient with MDT, and that they should have wraparound care. But in mainstream services, there should be homelessness leads. And I want to, you guys have a think about what that means for other elements of SMD. Should there be a drug and alcohol lead in every service where there's not specialist services across the country? All of these sorts of thoughts. And there's some information here about principles of care, which are kind of, I suppose, the things that are already happening patchily in different parts of the UK, but that the guideline brings together. And it would be, amiss of us if we hadn't mentioned the role that supported housing models has in meeting people's needs effectively, and by that we mean housing first. Support for staff was in there as well. So my final slide, one I did say I was going to give some time for questions, is I think this is a really important sort of, if you want to distill what it is that I think needs to happen and what I hope you're all contributing to, is that we are helping to achieve equity for patients. And really what we're interested in is that right-hand box. So when we're thinking about services, we're thinking, right, okay, what is it that we can do that maybe we are part of that box and not that stuff over there? And that's me, thank you.